Hi, everyone. My name's Diann Martin, and I really want to apologize that I'm not there in Las Vegas with you. But Chicago is undergoing an ice and snowstorm, and the flights were pretty much canceled today. So I was very pleased when Grace from the conference committee said that I could meet with you virtually and give you my presentation. So that's what I'm going to do. I live in the Chicagoland area, and I grew up and was born and raised here. I've been a nurse since 1974 when I graduated from Loyola University with my bachelor's. I then worked in community health, and I also worked at the Rehabilitation Institute of Chicago with physically disabled children and adolescents. And from that, I went into home care, and I spent the bulk of my clinical time in home health. I was formerly the director of the Chicago Visiting Nurses. I also had the opportunity to start the first hospice program in Illinois, and I've worked with both home health and hospices. 15 years ago, I decided to move into what I thought was going to be a kinder, gentler position, and I became the dean of a nursing school. Since that time, I've served as the dean or director at 4 different colleges, and I am currently the dean of nursing at Northwestern College in Bridgeview, Illinois. We're an associate degree program, and I'm going to talk to you today about the future of nursing and the implications for nursing education. It's a very critical time in our profession, and we're facing many challenges. So I want to review those with you and hopefully stimulate you to have a discussion at the session about some of what I cover. So I'm going to share my screen with the PowerPoints for the presentation, and I certainly hope that you were given copies of these handouts for your use today. And again, my apologies. Believe me, I'd much rather be in Las Vegas, where I think it's in the 70s, than here in the 20s with ice and cold in Chicago. So hopefully you can still see me up in the right-hand corner. And what we're going to talk about today is the current nursing workforce, the future demand for nurses, and some of the barriers that we face in meeting the demand. In the United States, some states have an abundance of nurses. Other states are really facing a severe shortage, and it's geographically and economically based. Generally, the larger cities such as Chicago, New York, Boston, Los Angeles have a decent supply of nurses, and their salaries tend to be higher. Other states like Arizona, Nevada, North Carolina, and South Carolina face shortages. We'll also talk about some of the forces that are going to impact nursing's future, and I'm going to review these before we go ahead. And then we'll talk about the implications for nursing education and practice. So we all know or many of us know, that the demographics of the United States is changing dramatically. The fastest growing part of our population is the over age 85 group. And by about 2025, every state is going to be like Florida, with over half of the population over 70. Now, in this country, we know from research that about 75% of people who live to be in the old category have significant impairments in their ability to live independently in the community. And right now, we simply lack the facilities or caregivers to provide what's going to be needed for that group. It's really the aging of the baby boomer population, and I'm part of that. So believe me, I know of the concern. We're also impacted greatly by technological advances. We're doing things in the home and in outpatient centers that used to require intensive care. At a conference I just attended, they were talking about surgical outcomes for ambulatory surgery to replace knees, shoulders, and other major surgeries. And people aren't even admitted overnight if it's possible. We also have technological advances that allow us to monitor patients physiologically at the bedside. We have technology that supports electronic medical records and the transmission of data. We're making great strides in cracking the DNA code of cells and providing medical treatment that's individualized to a patient based on their particular DNA strands. And the biggest use of that right now is in cancer treatment, particularly with breast cancer treatment. We're also in a period where consumers want more information, and they're beginning to partner with providers to influence the care and treatment that they receive. I mentioned that I was a visiting nurse in the community for about 30 years. And when I practiced, it was uncommon for patients to understand their diagnosis. They may be on a slew of medications. They didn't know the names of the medications or what they were for. I'll give you a great little story. In the early 70s, I took care of one of the first patients who had a coronary artery bypass graft. And I went to see her in her home when she was discharged. And she had a very extensive medication list. And I asked her if I could see her pills and go over them with her. She brought out a paper sack, and the pills were all on the bottom of the sack. The pill bottles were opened. And she said, you know, my grandson went to the pharmacy for me and got my prescriptions filled, but I couldn't open the bottles. So I had him open the bottles, and I just dumped all the pills in. And I said, well, how do you know what to take and when to take it? And she said, well, every once in a while, I reach in and take a few. And we've sure come a long way from that, with consumers reading literature reviews, looking on the World Wide Web for health information, and playing much more of a partnership role in healthcare. We still have a ways to go with this. We're also seeing increased specialization and expanded nursing roles. I'm a nurse practitioner, and I completed my practitioner degree in the 80s. And at that time, nurse practitioners were somewhat few and far between. And now the population of practitioners continues to grow and expand, as does their scope of practice. So we're going to be facing an older, more needy population in terms of medical care and personal care. We're going to be using technology to an extent that we never have before, and many nurses don't have a background to prepare them for this. And we're also seeing expanded roles. In 2010, the Institute of Medicine, working with the Robert Wood Johnson Foundation, issued a paper on the future of nursing. And one of their key recommendations was that nurses assume expanded roles and that their practice equate to what they're legally and intellectually able to do, and that the practice should be expanded. There was also a cry for more education for nurses and for more nurse leaders. So we'll be talking about some of these items as we go on today. So what's the picture of nursing in the US? Well, we are the largest group of workers in the healthcare industry. Right now, there are a little over 3 million nurses in the workforce, and about 60% of the nurses still work in inpatient settings in hospitals. Nurses are aging, however. The average age of a registered nurse in the US is 48, and for nursing faculty, it's 57. So the profession is graying, and I don't want to criticize my fellow educators, but many of us never learned the skills and the technologies that we need to teach our students. The number of graduates entering has increased steadily in the last decade, and it's continuing to grow. People are recognizing that nursing is a well-paying job. I looked this up today, and the average starting salary, the average salary of a nurse in the US, the median salary, I'm sorry, that's the middlemost salary, is $71,000. So by comparison, that is an excellent salary. And we're seeing more diversity in the nursing workforce. About 10 years ago, only 9% of registered nurses were male, and now that's up to over 13%. We're also seeing more minorities going into healthcare and into nursing, which is important. We're serving a very culturally and ethnically diverse group, and people have improved outcomes when they're working with someone of their own culture and ethnic background. I told you that the nursing workforce is growing. It's expected to reach almost 4 million by 2025. And the reality is, as I told you, some states have a good supply to meet the demand. Other states have shortages, and those are likely to persist. In states like Arizona, Colorado, North Carolina, and some other states. We know that the supply of doctorally prepared nurses who can lead large healthcare institutions, who can conduct research in nursing, and who can serve as deans of upper division nursing schools are way below the demand. I believe that currently less than 4% of nurses are educated at the doctoral level. This graph, and I'm going to talk you through it, shows the level of nursing education from 2013 on the bottom horizontal line, 2015 and 2017. Baccalaureate degree nurses are noted in the light blue. Associate degree nurses in the red line. Masters prepared in the green. Diploma nurses are dying out. Now, in the United States, at the time of World War II and after, the vast majority of nurses came out of diploma schools of nursing that were centered in hospitals. That is dropping down to just about 6 or 7%. Baccalaureate nurses are rising, and there was a movement, it's not going to be reached, to try to reach 80% of nurses prepared at the bachelor's degree by 2020. We're falling very short of that. And right now, the predominance of nurses at the bedside have associate's degrees. Now, the percentage of the nursing population with associates is dropping, while BSN and MSN is increasing. But when you think about MSNs being clinical specialists, nursing faculty, nurse practitioners, we're really far behind of where we need to be to serve the demands of the population. This is the age distribution of nurses. Remember, I said that we're graying. So the yellow percentage is from 2013. The blue line in the graph is 2015, and the green is 2017. And you can see that the curve goes up. The nurses in the over 65 group is growing. And as I said, the average age of the nurses is about 47. And for faculty, it's older, it's 59. And we don't have people coming into that field as much as we have a demand for it. We have to educate more nurses, and we have percentage-wise less faculty to accomplish that. One of the reasons why is that nursing education pays much less than a clinical practice job would do. So if a nurse is considering getting a master's degree, they may want to practice for a few years and then consider nursing education. The advantage of nursing education is the Monday through Friday nature of the job for the most part, and the fact that they get holidays and vacation time off. But their pay could be up to $20,000 or $30,000 less for a job as a full-time faculty member. So some of the implications that we see of the state of the nursing workforce is that we need to develop and streamline pathways for educational and career advancement. So facilities and schools around the country and around the world are working on programs like ladder education programs where someone could start out with an LPN degree and over time work themselves up to a PhD. And right now I employ 3 faculty who did just that. We're also seeing much more use of simulation. Simulation in nursing education has changed the complexion of care. When I went to school, there were no simulations or simulated learning. We went to clinical and we went to class. And if you happen to be in a clinical site or experience where not much was going on, you didn't get to experience critical items. One example would be a postpartum hemorrhage. It's a very serious complication in labor and delivery, but it's unlikely that the student will experience that. Now, we can offer that opportunity in the simulation lab, and we're seeing that the state boards of nursing are allowing schools to use simulations, and there are levels of simulators from low fidelity or just a basic mannequin or an arm to give an injection in, all the way up through high fidelity mannequins that can be programmed by the computer to talk, to display physiologic monitoring, all the way from pulses and breathing to EKG strips and so forth. The human patient simulators are very, very costly. The high fidelity mannequins can run over $200,000 a piece. So schools that use this resource pay a high price for it and pay a high price for outfitting their laboratory for simulation. At my school, we just set up a system for new microphones and two-way video cameras in our simulation lab. And the price was just for the video was over $40,000. And at a small college like ours, that is a big expense. In Illinois, the state will allow us to substitute up to 25% of our clinical time with simulation. So if students miss clinical or are sick or something, they can come in and make up the time in the simulation lab. And the technology is extraordinary. The control panel requires advanced training in simulation and technology. And the mannequins are costly, not only to obtain, but to keep updated. One of the things that we're seeing, because nursing education is so rapid and there's less time for clinical practice, many schools and many hospitals are developing residency programs for new nurses. I believe this is a very appropriate activity and something that more and more systems should look into. When you think about it, physician education is equally rigorous or more rigorous. And when a physician graduates from 4 years of medical school, they then do at least 1 year of an internship and up to 3 to 4 years of a residency, where they're working under the direction of a mentor or an attending physician to really integrate and be able to apply what they've learned in the clinical setting. And as nursing care becomes more complex, I believe that this is a very effective tool to help support new grads. I also want to mention something here. I just did a literature search on new graduates, and unfortunately, only in about 70% of cases, new nurses were not able to demonstrate critical thinking and sound clinical judgment. The new nurses who weren't able to make good clinical decisions and use critical thinking accounted for about 60% of the errors, the nursing errors in healthcare systems. So we have a real demand to do a better job and educate our students in clinical reasoning, decision-making, and analysis of patient problems. We're also seeing more interdisciplinary courses and lab work. At my school, we have a medical assisting, a surgical tech, a dental tech, and an X-ray therapy track. We're organizing a disaster drill that will incorporate all of the different disciplines in response to a bus accident, and the students will work together in teams to come up with treatment plans. We're also seeing a big move in the US away from hospital inpatient care and to outpatient, ambulatory, community-centered healthcare delivery, including telemedicine. When I was in my master's and doctoral program, I was the director of the home care program at a major medical center in Chicago. And we beta tested a telemedicine system that did home physiologic monitoring from a station and transmitted the data to the physician. It also dispensed the patient's medications according to their time schedule. And the system could even record an EKG all in the patient's home and transmit the data remotely. Those types of services are going to be effective in allowing more people to move their care into the home. And as I said earlier, we're also focusing more on human genetics, and we're able now to tailor, particularly with cancer patients, we're able to tailor treatment directly to the individual's DNA strands. This is being done in breast cancer treatment and several other forms of cancer treatment. But as we learn more and can decode the human genome, we'll be able to practice more individualized patient medicine. So what are some of the challenges we face in nursing practice and nursing education? In both instances, recruiting and hiring experienced educators and experienced staff is a major challenge. Also, providing the resources, time, and technology that's very costly to keep nurses on the leading edge of healthcare. And I'll just give you one example from my experience. Electronic records have been around for a while, but when they really went into wide use, our faculty had absolutely no experience. Many of them were not computer savvy, even with their own home PCs. So having them try to teach the students how to effectively use electronic records was a disaster. And the way that we've dealt with it more recently, there are simulated electronic health records that can be programmed along with the scenes that we use in our computer simulations and our human patient simulators. We can create charts, we can create databases, the nursing students can learn to record their findings and their progress notes and health histories using simulated electronic records. Another challenge is selecting and admitting qualified students. We need to make sure that the people that we admit can handle the rigor of the math, the science, and all of the complexities of care that modern nurses face. Many people can come into the program, but may not be able to handle the rigor, and they struggle in school. We have tutors and remediation plans to help and support people, but there are a certain percentage of students who don't make it. Another challenge that has happened and is increasingly a problem is securing clinical sites and clinical partnerships for students. When I was at the Chicago VNA, we had many, many, many different schools of nursing seeing our patients and working in our setting. We felt it was a way to give back to the community and to the profession. Once healthcare economics changed in the 80s, what used to be this nice favor you did for students became a cost. So the time and cost of the hospital nurses involved in teaching new students made it a barrier for hospitals to allow nursing students to practice in their site. In many cities like Chicago, the baccalaureate programs have the lead in securing sites. Hospitals enter into clinical partnerships with schools, hoping to recruit and hire some of their staff. And in some of the large medical centers, they prefer to hire BSNs. So they're less likely and less inclined to allow associate degree students to come on site. And I don't think it's really a secret. It's called a lot of different things, but it's much more common now for schools to have to pay facilities to place their students in clinical. They may call it something else. They may call it a supply cost or an instructional cost. But the fact of the matter is the school has to put money on the table to be able to send their students for clinical. The increased complexity of patient care and treatment is another major factor. The level of care in a cardiac ICU or a critical care unit of any kind may be well over the mark for a student to participate in the care. So we need to find creative ways to educate our students using case studies, using simulation, and using other creative strategies. So sorry, I have to go back here. Sorry about that. I mixed up the order of the slides. So we talked about the challenges that were being faced in nursing education at a time when there's a huge demand based on the aging of the population and other factors. So what does this mean for nurses and nursing students? It's important, I believe, to seek the highest degree level that you can handle and that you can afford. Also, that you identify a specialty. And one excellent feature of being a nurse is that you can move across specialties and settings. So someone could be a med-surg nurse and then move into occupational or school health, and then maybe into critical care or surgery, and all within the scope of their nursing degree. We obviously have a major need to stay current with technology and informatics so that when we enter the healthcare setting, we're prepared to work with the equipment and supplies that are available. We also need to be politically active. Nurses have an ability to be a major political influence as a group, and we often do not capitalize on this. I encourage my students to take a stand in a race or in a piece of legislation that's going to support nursing, and get involved in your nursing organizations. I also encourage nurses to seek leadership roles within healthcare and within nursing. I recently learned that within 6 months of graduation, most BSNs will be in a charge role or a leadership role. And we also need to offer kindness and support to other nurses and students. One of the biggest reasons that nurses leave the profession is termed lateral violence, but that really boils down to treating each other like crap and being critical and not lending a hand. There's a saying that nurses eat their young. Unfortunately, that can be all too true, and it's very unnecessary. So some of the practice implications of what we've talked about is, as I mentioned, increase in technology, increasing levels of specialization, a continued decrease in inpatient stays. When I entered nursing, the average length of stay for a hospital patient in Chicago for Medicare was 14 days. Now it's 3.5 days. So people are hardly getting the bed warm before they get discharged. There's more and more of a shift to outpatient and community-based care, and a focus on, again, a renewed focus on health promotion and disease prevention. And I welcome that. It's much better for our society if we pay for the cost of prenatal care for high-risk mothers than the care and treatment of an infant that's born with multiple complications or prematurity. There's also going to continue to be pressure to hold down cost at the same time that we improve quality and that we decrease errors across all settings. Nationally, also this came out of the Institute of Medicine study, we need to place significant time and energy into educating staff and students on evaluating the risk of different procedures, noting problems with safety and addressing them, and avoiding medication errors. The third leading cause of death for hospital patients in the US is error. And that is a sad commentary that we all have to be responsible for and responsive of. You shouldn't get sick by entering a hospital. You're there to try to get well or improved. So I'd like to leave you with my idea of the implications for all of you and your careers. First would be to be a lifelong learner. That might be getting another degree, It might just be staying current in your specialization, attending seminars and workshops like this, reading journal articles, joining a professional organization in your specialty area, and if possible, to seek a higher level of preparation. Prepare yourself for a leadership role. Nurses need effective leaders who nurture the work they do, inspire them for improvement, and provide astute leadership. If you are in a healthcare setting, take the time to support any students who are in your environment and mentor and support them to the best you can. Stay as current as you possibly can in your specialty area and promote the nursing profession. Nursing has a rich, proud history. All of you carry that history within you as you practice or teach, and I encourage you to share that expertise when you talk to others about what you do. If somebody says, "What do you do?" I am a nurse, I'm proud of it. My mantra is that nurses change lives, and I would support you in changing yours. So again, I want to thank you for coming or for listening to my presentation. I'm sorry I wasn't able to be there live and present for you, but I'm happy if you want to get in touch with me. My email is Diann, Diann, Mar, M-A-R, at AOL.com, and I'd be happy to get back to you. So with that, I'll sign off, and I hope you enjoy the rest of the conference.